Let's jump right into this explainer. Today, we're targeting high-yield head and neck emergencies. Look, in high-stakes clinical assessments and more importantly in actual practice, identifying the exact pathology in these presentations isn't just an academic exercise. It is an absolute life-saving mandate. Why? Because the anatomy of the neck guarantees that inflammation doesn't just cause pain. It actively compresses the respiratory tract. We have to recognize the precise clinical signatures of these diseases immediately, or our patients will asphyxiate.
We have to establish the lethal stakes of misdiagnosing these conditions right up front. Think about the clinical variance here: unilateral jaw pain versus a massive bilateral bull neck. Now, one of these could just be sialolithiasis, a salivary stone. We know that overwhelmingly targets the submandibular gland, specifically Wharton's duct, because of its long, tortuous, upward-flowing path and that highly viscous mucin-rich saliva. The kinetic signature there is unilateral colicky pan that strictly peaks during meals and resolves hours later. You manage that conservatively: hydration, NSAIDs, and silagogues, like sour candies, to literally flush the stone out. But the other presentation? That is a rapidly expanding anatomical disaster that requires immediate, definitive airway control. Treating a deep space infection like a simple localized stone is a lethal trap.
Section 1. The suppurative infection, acute parotitis. Let's break down this highly localized glandular infection. This postoperative threat overwhelmingly targets very specific vulnerable profiles: the elderly, the chronically dehydrated, or patients in the immediate post-op period experiencing massive fluid shifts while strictly NPO. The classic exam vignette is unmistakable. You'll find a firm, exquisitely tender mass right at the angle of the mandible with unilateral erythema and severe edema over the cheek. And if you examine the oral cavity, the absolute kinetic signature is purulent discharge that you can express directly from Stenson's duct.
The mechanism here is driven strictly by retrograde bacterial migration, primarily a staphylococcal surge, Staph aureus, and mixed oral flora traveling right up into the gland. It happens because these high-risk patients lack the normal continuous salivary flow needed to wash those bacteria away. Often, the structural trap is a parotid duct obstructed by a stone. That calculus acts as a nidus, completely halting flow and inviting that bacterial surge. Your management mandate? Aggressive rehydration and immediate IV antibiotics.
Section 2. The localized accumulation, paratonsillar abscess.
All right, we're escalating the threat level now. We're moving from an external glandular infection to a localized structural risk directly inside the airway. With a paratonsillar abscess, your patient is going to present with a severe sore throat, trismus, that profound spasm preventing them from opening their mouth, and that classic muffled hot potato voice. But the absolute critical visual cue here is massive edema of the tonsil, diffuse yellow exudate, and the uvula visibly shoved over to the opposite side. Because this localized pus pocket sits right between the palatine tonsil and the pharyngeal muscles, it is an active structural threat to the airway. So what's a strict intervention mandate? Immediate needle aspiration of the paratonsillar space. You absolutely do not delay source control for a CT scan, and you do not prioritize IV steroids. You forcefully address the threat with aspiration, followed by broad-spectrum IV antibiotics.
Section 3. The lethal floor, Ludwig's angina.
This is the climax of our explainer, the most catastrophic, life-threatening emergency in this entire block. You have to know the root trigger. This rapidly progressive bilateral cellulitis of the submandibular and sublingual spaces is an odontogenic catastrophe. It overwhelmingly sparks from an infected second or third mandibular molar, almost always in a patient with a history of terrible dentition. That single localized dental infection is the spark that ignites a massive anatomical fire.
Let's walk through exactly how this turns fatal. Step 1. That polymicrobial infection breaches the deep fascial planes. Step 2. It triggers rapid, bilateral cellulitic edema, creating massive, woody induration. Step 3. Because this swelling is trapped by tight fascial layers, it has nowhere to go but up and back. It acts literally like a physical jack, violently forcing the floor of the mouth and the tongue posterior and upward. Step 4. Total obliteration of the oropharyngeal airway. And I need to emphasize this strongly. This is strictly a cellulitis, not an abscess. There is no collectible pool of pus in there to drain.
Burn this concept into your memory. Asphyxiation is the most common cause of death here. The strict medical mandate is that you continuously monitor for respiratory failure. You absolutely must not lay this patient flat. because gravity will instantly finish the job of closing their airway. You have to secure that airway immediately via awake fiber optic intubation or an emergent tracheostomy long before cardiovascular collapse sets in.
Let's rapidly contrast these profiles so you never mix them up. On the left, acute suppurative parotitis, unilateral swelling at the jaw angle, usually in an elderly, dehydrated, or post-op patient. The fix is IV antibiotics. On the right, Ludwig's angina. This is your rapidly progressive bilateral bull neck. The patient is severely drooling, has dysphagia, and an elevated tongue. The definitive mandate here is immediate airway intubation. Recognizing this specific variance is literally the difference between life and death.
Section 4. The Master Case. Testing the Nuance. Welcome to the Diagnostic Crucible. We're going to integrate these pathologies into a high-stakes assessment. Here is your clinical blueprint. A 45-year-old male with poor dentition comes in with a 2-day history of a rapidly worsening fever, severe drooling, and massive bilateral induration under his chin, a classic bull neck. Most importantly, he is leaning forward to breathe. The prompt demands the most appropriate next step. I need you locking in on those kinetic markers, the severe drooling and the positional breathing. Those signs scream that this is an unprotected airway on the verge of total collapse.
Let's execute a rigorous breakdown of these highly competitive options. Option A, IV antibiotics. Medically necessary, sure, but utterly fails to address the immediate lethal threat of asphyxiation. Option B, a CT scan. That is an absolute death sentence. Forcing this patient to lie flat in a scanner will precipitate immediate respiratory arrest. Option C, needle aspiration, is incorrect because we are dealing with a diffuse bilateral cellulitis, not a localized abscess. Option D is the strictly masked surgical trap. That severe fluctuance mimicking induration aggressively tempts you to diagnose an isolated submandibular abscess. But remember, Ludwig's is a cellulitis. Scalpel-based drainage will yield absolutely no pus and causes a fatal delay. Therefore, option E, endotracheal intubation, specifically awake fiber optic intubation, is the definitive, uncompromising, life-saving mandate. Bottom line, when you recognize the catastrophic kinetic signature of Ludwig's angina, you must forcefully bypass all scalpel-based drainage and imaging. Secure the airway first. Your deep anatomical knowledge has to translate directly into immediate clinical action. Think about it. If your patient suddenly lost their airway in the CT scanner because you ordered an image instead of intubating, would you truly be prepared to perform an emergent awake surgical airway on a massively distorted bull neck? Probably not. Keep that reality in mind, study these blueprints, and I'll see you in the next explainer.